Hi, my name is Eric Bansal. I'm a second-year interventional fellow at Case Western University Hospital in Cleveland, Ohio. I just wanted to thank everyone for having me and allowing me to present this case today. So the topic of, or the title of my presentation is Using OCT to Make a Complex Intervention Simple. So this is a case of a 53-year-old male with history of hypertension, hyperlipidemia, who was actually referred to University Hospital for rotational atherectomy of a diffusely calcified LED lesion seen on angiography at one of our satellite university hospitals. The patient had reported some substernal chest pain with moderate exertion, and this actually, interestingly, all started when the patient had an elevated calcium score about 6 months prior. He subsequently had an abnormal stress test and was referred for diagnostic angiography. On physical exam, vitals are pretty unremarkable. Physical exams are unremarkable with the normal or creatinine of 1.2. This was his calcium score. Actually started his whole work, and as you can see, the driving force of this elevated calcium score was an LED calcium score of 917. And so he was referred for diagnostic angiography. This was done at the outside hospital, showing the right. It's just short left main, and they were selectively engaged in the circ, but we can see eventually that there is some better pictures of the LED and the calcification that is in the LED. I think this picture probably shows it the best, showing a diffusely narrowed mid-LED with severe calcification angiography, where you can see the outline of the vessel due to the calcification on both sides of the vessel. Again, more angiography that was done, just kind of highlighting the significance of that LED stenosis. So he was referred to our institution for rotational atherectomy. So just kind of going over the goals of the atherectomy would be the equipment delivery, calcium debulking, and calcium fracture loss stent expansion. And so we often use OCT prior to any atherectomy case to kind of identify where the significant calcifications are and to kind of figure out what is the best approach to these patients. And we often use this kind of treatment approach where if there's concentric calcification, meaning greater than 270-degree arc, we go to atherectomy, but oftentimes we're able to avoid atherectomy if we find that the eccentric calcification is not concentric, and it often changes our management style. So in this case, as we often do, we use OCT almost exclusively in these patients, and this is our OCT run of the vessel. There is a tightly narrowed segment in the mid-LED just prior to that diagonal. But as I will show in the subsequent slide here, so looking at OCT, we ask ourselves 3 questions: will the calcification prevent stent delivery? In this situation, there is there's still a prominent lumen there. Will the calcification prevent stent expansion? And this kind of breaks down the calcification in this vessel. And as you can see here, I kind of highlighted the calcification in the lower panels of this picture. In panel 3 here, which is the worst area of calcification just prior to that diagonal, the calcification is more on the 180 arc, but definitely not 270. So in this situation, and then also based on the OCT, we were able to identify good landing zones for our stent. So going back to identifying this calcification pattern, we felt that we actually could proceed with stenting this lesion, and our stents would probably be D-shaped stents, but we would achieve good lumen gain. So OCT in this case, the calcification was thick but eccentric, so it would allow adequate stent expansion against that non-calcified wall. There's good landing zones present, and so we actually proceeded to direct stent this vessel with a zeralized eluting stent at 2538, which is post-dilated up to 3.0 at 20 atmospheres. This was our result after our initial stent. We decided to treat the diagonal, which was treated with a 3.0 and then eventually kissing balloons into the LED. This was our subsequent picture. We did repeat another OCT run, and kind of based on operator preference at this point, there was an area of stenosis a little bit proximal to where our stent landed, as we'll get to that here in this OCT run. And kind of a little bit subjectively, I'll admit that we decided to stent that lesion as well, so that was stented with another stent at 3.012, post-dilated up to 3.5. This is our final OCT run here, showing our final results with with the 2 stents in place now. I will break this down here in the next slide. I just wanted to go over it and let it play in its entirety. And this is our final angiogram. And so basically in our final OCT, we had no edge dissections. There was no significant malapposition. And we had adequate stent expansion, which is largely assessed by the lumen profile, and all of this made for successful PCI. So we avoided a trapped rotoblator burr, and we avoided all atherectomy, and we were able to successfully treat this patient, and OCT greatly facilitated us making this challenging case simple.
Very good. Any comments?
No, it's a great case.
Good use of technology to simplify it. It's too bad the CT can't tell you if that's circumferential or not. It would be also very nice, but the blooming artifacts tend to make it a little inferior in that regard. Very good. Our next presenter is Dr. Amir Alati. Think outside of the box.
Hi everyone, thank you all for being here today. Okay, exit. While it's loading, just want to ask like how many interventional fellows in the room, if you can raise your hand. Oh, that's it. Well, I cannot ask any questions then. Okay, so my case title again is Think Outside the Box. And so 48-year-old female with no known cardiac history, she presented to outside hospital ED September 15th with acute worsening chest pain and also like 3-month history of worsening chest pain on exertion. Past medical history, nothing cardiac. Surgical history, just knee replacement, hysterectomy for abnormal uterine bleeding. Family history of hypertension, CAD in the mom's side. She denied smoking, but she admitted to smoke marijuana every day. And meds, just anti-anxiety, no allergies. So her, like, just a quick summary, like how her symptoms evolved. She really described like discomfort in chest for about 3 months duration, substernal, some mixed kind of typical and atypical symptoms. Then in August, she presented to outside hospital ED with a chest pain, 10 out of 10, sweating, nausea. Troponins were negative, EKG, no acute changes. She was labeled with anxiety, discharged on Xanax. She went to Jamaica for a vacation, September, and there she had also some atypical symptoms of cough, URI symptoms, also acute chest pain. So she eventually presented like on the 15th September with chest pain after going to urinate. She felt acute chest pain with diaphoresis, dyspnea on exertion, nausea, vomiting, more typical symptoms. Obviously, like any patient going through the ED, she got CT-APE study that was negative. She this time, if you just look like. Is it like, okay, so basically in August, she had negative troponin. Upon presentation, she had troponin of 0.08, and this time really peaked into like to 1, which is really concerning. This is the EKG in August. This is the EKG this time, which is really more concerning with, kind of well on kind of sign. On the EKG physical exam, nothing remarkable. She had chest wall tenderness for whatever that was. Okay, so the angiogram. Like just quick question here, like anybody concerned about anything in this images? Kind of ectatic looking, proximal LAD, even the left main, and weird takeoff of the LAD. Obviously the cranial view, you see the LAD here, kind of ectatic. And in this view is like really diving down and then up in this RAO caudal. So just like any, if you're really concerned about the clinical scenario, just like any other case, you take more views. And in this view, which is RAO caudal, but more kind of maybe steep RAO, there is this ostial lesion, or whatever it is, something suspicious in the ostial LAD. With this history, this is the RCA and the LV-gram here, LAD distribution, wall motion, abnormality. So I think it's not unreasonable to have like SCAD and differential diagnosis. And the operator at that time felt, she is hemodynamically stable, you have Timothy flow in the LAD, ostial LAD. If it is a SCAD, if you try to intervene, you might just make things worse all of a sudden. So the plan was to send her to our center, cardiac ICU, and really we kind of discussed the options. If you're concerned about SCAD, I'm not sure if anyone concerned about anything else at this point. Kind of, conservative management, maybe watch her, see how she does, the PET cath or imaging, the CT, you don't want to rush her to the cath lab. But you consider like cardiac surgery just to see the patient in case she become unstable. She was hairplanized, monitored, and as we discussed. So she was having more chest pain just because of, to cover, a kind of heart team approach, we called CT surgery, and she was very, very upset. She said no, she kind of kicked him out of the room. She doesn't want to consider any options of open heart surgery. But she had, it was a weekend. We kind of were trying to put off things like, let's just wait, see how you do because, the concern of SCAD. But she had worsening chest pain. On the Sunday, we just kind of looked at the CTPE that she had. There was like unusual, obviously this is not, optimized to evaluate coronaries, the contrast NDPA, but you can see like there's calcification in the ostial LAD. There's nowhere else, any calcium anywhere else. Okay, so we repeated cath on a Sunday, looking the same. Obviously, you would like to get more data, and I think everybody would agree you would try to maybe image it. Maybe consider FFR if you want to intervene. Anyway, for the sake of time, very difficult to wire. Angulation, severe lesion, you cannot really open up in any good view. We used supercross, and with difficulty we were able to wire it. We did FFR just to kind of complete the evaluation, and very ischemic. And we did OCT. And the OCT, you can see it's like really big vessel. Don't worry about this, it's just artifact from a huge vessel. Kind of, you see how the OCT is kind of biased into the other wall here. So there is no evidence of atherosclerosis. Here's the transition from the LAD to the left main. I will repeat that because that's the key here. So again, the things that we were looking for, no atherosclerosis. So we're not dealing here like with a athero lesion. There is this transition from the LAD into the left main. Very unusual. Again, no athero, it just looked like a kink or a twisted artery. This is not a great image. This is 3D reconstruction of OCT, but because of the artifact and the, all of these things, but you can appreciate how the LAD here and the left main, and this is like kind of twisted and kinked. Then obviously the next question is how do you deal with this? We obviously already kicked out the CT surgeon from the room, from her room, she did. So there's no option of surgery. Obviously PCI, we went with a larger stent. The actual left main was like 10 millimeters probably, LAD approximately, also probably 7, 8, a huge vessel. You can see how the wire is biased from like this wall in the left main to that wall of the other wall of the LAD because of the whole anatomy is strange. Went with a larger stent, 5 by 12, and we just deployed it. And we did another OCT. It's just the final results here. Okay, kind of straighten the segment. Obviously, I think everybody wants to know how the OCT looked like after this, and this might spark like a lot of questions. We're happy to discuss it really quickly, but for the sake of time, I'll just scroll here, show you. You can see the stent. I admit the stent is floating in the LAD, but again, it's like about 8 millimeters or even more vessel here. And this is the kind of the segment that we kind of straightened with the stent, and it's floating also in the left main. We did not post-dilate. I think we can open that to discussion quickly, but we did not post-dilate. I think for this, the whole idea here is to support that segment. We're not dealing with atherosclerosis, we're not dealing with a lumen area. This is like the left main was 32 millimeters square. similarly the LAD, so we're not worried about stent thrombosis. And you don't want to deform the stent because then you lose the whole idea of supporting that segment, the kinked or twisted artery. Okay, I think I already showed you this, but before and after, and thank you all for the attention.
Very good. I had one case just like this on a young patient, 30-year-old, and she had a scleroderma crest syndrome. And I think that, totally clean arteries, no atherosclerosis anywhere else, but just focal.
Just like focal,
LAD.
okay.
And we ended up sending it just like you did. I think it's an open question whether you should post-dilate this one with a peripheral balloon. I think that's a reasonable question here, given the size of these vessels. But
You probably never get apposition from what he's describing, so you might mangle the stent. One thought is to use a renal stent, Herculink or something that you can take bigger.
I think that anyway, I think it's very risky. I think that if you dissect proximal or distally or in big problem, then the patient may go into a path of no return because it's almost immediate shock if you either dissect distally or proximally. Sometimes the heating can be like tissue paper, especially in a young female. She's 40.
She's 42, 48.
42.
Yeah, in the
so
40s.
I would think about non-atherosclerotic.
Yeah.
Even though she had calcium, you showed calcium.
So that
there, or
calcium,
stenosis?
that calcium, I think she had like long-standing issue in that segment. Inflammation from a kink, that progressed over time and then acutely worsened. So there was like some focal, abnormality there for a long time. That's why she had calcium there, but it was not atherosclerosis.
A mid-cab or something that is less invasive and secures. I mean, that's definitely significant. So the only problem is that there's so much inflammation that this may open up in the future. If you put a graft, the graft may not work, but at least to get you out of the problem. But it's interesting. It's an interesting approach.
fortunately, we know that stent expansion is adequate, and so you don't need as much apposition. It's
Exactly.
stent expansion that's the risk
Exactly.
for stent thrombosis. So I think you did the right thing leaving it alone. Let's move on to the next.
One comment, as big as this artery is, it's like an SFA in the heart. And so basically, there is so much twist that, people have used self-expanding stents. And, that could be one option to actually put in a self-expanding stent. You get, a much bigger lumen. You can post-dilate it. You probably have less risk of dissection, perforation at the edges. Exactly, a carotid stent, I've not used it in the LAD, I've used it a couple times in the RCs. But I mean, that might be another option just because the way it is, it's,
Yeah, that's a great point. That's why you guys are all dual trained in vertical. It's wonderful.
Hi, very nice presentation. So the presentation of this patient was ACS, was it?
Yes, the last one she presented with was ACS.
The reason that you put in stent was ACS?
I mean, yeah, because she had like this time NSTEMI, it's a 0.1, LV wall motion abnormality, like EKG changes, everything was consistent with, and FFR was 0.5. Yeah, we did FFR, yeah, it was 0.5. We were trying to do everything that avoid doing anything, intervention, but we couldn't.
All right, we're going to move on to Dr. Thank you very much.
Thank you.